Eastern Ontario. And most important, we have our guest panelists. We sincerely thank them for participating in this webinar, and each will be introduced immediately ahead of their presentation. The purpose of today's webinar is to facilitate HealthLink to HealthLink learning and sharing. As you learned during the initial HealthLink's Community of Practice webinar a few weeks back, Health Quality Ontario has established a process for evaluating innovative practices. You can learn more about the Best Practices Framework and the Innovative Practices Evaluation Framework by viewing the webinar on the HQO website. And it's listed under HealthLinks, and it's called the Innovative Practices Framework. We interviewed leaders from the early adopter HealthLinks and harvested innovative practices that have advanced the objectives of HealthLinks. Then, using the Best Practices Framework, we evaluated those innovations, looking for practices that should be considered for large-scale spread. Throughout this HealthLinks Community of Practice webinar series, we are profiling innovations that have contributed to improved processes for coordinated care planning. In the next few slides, we will provide an overview of the practices we identified relating to patient interviews, how care teams can obtain key information about HealthLinks patients, their lifestyles, their health, and their wellness, as well as understand from their perspective their health journey and their goals. This will be followed by presentations from our guest panelists who will share processes and key learnings focused on the third step in the coordinated care planning process, interviewing the patient. I pass the baton to Jennifer.
Thank you very much, Sandy. So to review, the image that you see on the screen represents the high-level steps in the care coordination process that organically grew out of the work of the early adopter HealthLinks. Most HealthLinks have adopted or adapted some or all of these steps in their processes and practices. Our first webinar focused on the first step, identifying the patient. Our second webinar focused on engaging the patient. And today's webinar will focus on the third step in the process, the patient interview. My apologies, I can see that we can view the yellow circle, but not the image behind it. We'll make sure that we correct that ahead of posting it online. This step that we're speaking of today typically involves a conversation with the patient to learn more about the patient and his or her health journey. Additionally, at this point, the care in the process, typically the care coordination process, including the patient's goals, etc., are established. At this step, some HealthLinks also begin to make decisions and plan for the care conference. Again, while the general elements of the patient interview step are similar across the HealthLinks, there is variation in the practices used. We'll hear more soon from our guest panelists about how they have approached this step in the coordinated care planning process and what they've learned along the way. Next slide, please. The themes that emerged from the lessons learned collected so far from around the province include the following. The first theme focuses on the increased emphasis on understanding the patient story and the development of goals from the patient perspective, which echoes the overarching focus on patient engagement and patient experience in the work of HealthLinks. Then there's the theme around clinical approaches to the interview. To capture the patient perspective and support patient-centered goal setting, some HealthLinks draw upon validated interviewing theories, techniques, etc., and have created standard work processes. Other HealthLinks look to draw upon specific skill sets by selecting particular professions or providers to complete the interview, or by looking at general capacity building around interviewing skills. Another theme is around patient empowerment, where we see the patients encouraged and supported to be a partner in the care planning process in elements such as goal setting and decision making about their care team and care conference. The message here is to empower patients to participate in the interview and make decisions in their care, yet respect the wishes of patients who prefer to be supported in a different way or wish to defer to family, caregivers, etc. Where the patient interview is conducted is another theme that's emerged from the lessons learned. Some HealthLinks aim to conduct the interview at the patient's preferred location, such as their home or a neutral location. And note that the benefit of this is knowing more about the patient and getting to know them in their own environment. Others conduct the patient interview in a clinical setting, embedding the interview into existing assessment processes, which creates efficiencies, increased throughput, etc. And yet others are exploring technology. In general, it appears to be generally accepted that the patient interview is ineffective if it's approached as a form-filling exercise. It's not about getting the sections of the CCP filled out, it's about understanding the patient and the patient's goals so that their care team can better support them to achieve those goals. And with these themes in mind, we're now going to turn our attention to our guest panelists to hear more about their specific practices that they've been exploring, trialing, and implementing. As you're listening to the presenters, please feel free to type in any questions you have into the question box. I'm now going to introduce Chris Archer and Tracy Koval, and they come to us from the North Simcoe Community Health Link. Welcome, Chris and Tracy. We're just looking to unmute you on this end. You two appear to be unmuted on our end. I'm wondering, Tracy and Chris, if you happen to be muted on your end. Okay, while we work out those technical glitches, I think we'll move along, and I'm going to introduce Dwayne O'Connor from the Barrie Community Health Link. Good morning, Dwayne.
Hi, can you hear me now? Hello? Hello, can anyone hear me?
I can't tell you I can.
Yeah.
So I'm on this, so I can hear
Oh, you're on this?
Yeah. I can hear you.
Nobody.
I can't answer you.
Are you able to hear us?
I can hear you now.
Okay, wonderful, thank you. Is this Dwayne we have on?
This is Dwayne, yes.
Okay, Dwayne, welcome. We're going to move into your slide deck if you'd like to begin. Thank you, and thank you all to our audience for bearing with us through the technical difficulties.
Thanks.
Okay, Dwayne, you're welcome to begin.
Okay, next slide deck, please. Next slide, I mean. Okay, so in our particular practice, in the MVP clinic or Most Valuable Player clinic, we do a lot of patient-based interviewing. Our interviews are all done on a case-by-case basis. In addition to our standard tool that we use from the referral, we use an allied health screening tool and an allied health assessment for OT and social work tool. Now these were developed by our particular team, including our nurses and our occupational therapist. We just recently have a new social worker, so she was not involved in it, but she approves this particular one. Next slide. Okay, because our people are seen on a case-by-case basis, and when I say that, I mean that we get different referrals in for different reasons. We have referrals that come in asking us to triage people based on certain types of medical comorbidities and the combination of medical and psychiatric comorbidity. And what we do is make a telephone call to that particular person to get the basic information and qualify the patient based on their initial referral. When I say qualify, I mean basically ask them straight to their face to ask them if they agree that they have these particular ailments and or illnesses and or issues. If they agree with those, then we take them to a second step process where we'll bring them into the actual clinic and we do an in-person intake with IHPs working closely together in the same room as the patient to assess their needs. So during the time after we finish going through the entire referral form process, we sometimes are able to discover certain other things that are not necessarily listed in the referral form. We ask them things based on family, what clinics they've been involved with, what other areas they've actually been seen, do they have a family doctor? If they don't have a family doctor, how can we help them? Have they seen other community partners, and how we can actually assess those particular areas. Then we actually use those interview tools I spoke about from before. Next slide, please. So we evaluate and review the reasons for the referral, like I said before. And the reason that we do this in person is because a lot of times you can actually feel out with what's happening with a particular person. If they have barriers or have received any sort of challenges from their previous experiences, we try to make sure that we can overcome those experiences and actually challenge that with them to make sure that we're covering every possible health links related issue. Many times we'll call in other IHPs into the same room. So in case we are, say if a nurse is doing the initial intake, we find that there's some social determinants of health issues or things that a social worker would be best in. We have a social worker in our particular clinic. We literally call over to the social worker, and then the social worker joins us in on the intake process. Same thing with a nurse practitioner, an occupational therapist, a mental health and addiction specialist. We do the same thing there. And while we're doing this, we're documenting those concerns very, very detailed, and we're trying to make sure that any of the different IHPs that we have inside the clinic or outside the clinic who can assist will be involved in this process. We interview further to identify the services in the community, not to mention when we do have our patients that say that they have seen certain people in the community, we will document that, have a session with the community partner to help them understand where their particular patient is now in our particular clinic, what's going on with them, what's been explained, try to make sure that we're getting correct or qualified data. Once we do that, when we have our team evaluating fully the patient, we'll call them to actually have a patient round to discuss the patient case and continue on from there. Next slide. Our lessons learned is that we absolutely must understand the social determinants of health. We must be aware of all the aspects of the patient's needs, including their family, who may or may not influence what's happening with them at home or in their particular care, not to mention their pharmacist, if they have a particular issue going on with multiple medications onto several pharmacies. What we'll do is actually streamline those to go to one particular pharmacy instead of going several different places. We will validate all the information that the patient's told us. If there's other needs that we cannot overcome in our particular clinic, we'll try to make sure we make the connection to the right place in the community. And we also have learned that all of our patient intakes, no matter what's going on, they usually take longer than an hour. And sometimes they can get even longer than that, to the point to where it's 2 hours at a time. And we're just making sure we're fishing out all those particular things to make sure that the patient is getting their needs met. Next slide. Okay, and that's our contact information. So if you have any referrals out there, you feel free to fax a referral. If you need me to send referrals out, I'll be glad to do so. And you can give us a call anytime, and we can actually send it from our other current area. Any questions?
That's wonderful, Dwayne. I do believe we have some questions on the line. I'll pass the mic over to Stacy.
Hi, Dwayne. There is a question asking, does the patient decide who will join the interview, or does the interviewer decide?
Say it again. Sorry, I didn't hear that last portion.
Does the patient decide who will join the interview, or does the interviewer decide?
The interviewer decides, but we always ask the patient's permission.
Okay. And then there's another question asking you to describe the tool that you talked about briefly.
So the health assessment tool and that sort of thing? So those particular tools, or you mean the referral form?
Have they asked which tool specifically, Stacy?
No, they have not.
Okay, so in our particular tools, what we have done is actually seen those different needs that are quite common in our particular area. And what we do is we put those into the particular tool. So we've asked certain things like family members, who speaks for you, who's the social worker that you've been seeing. If you have been seeing a social worker, what are the family issues that you're having at home? Do you have a homing issue, housing issue? Do you have issues dealing with food? Are you receiving food regularly? Are you having food security issues? And not to mention, are you feeling safe? Are you feeling safe in your current environment? How are you getting back and forth to your particular appointments? Have you been getting back and forth to your particular appointments? Who have you been seeing on the most common basis, say the emergency room, which quite often is what we get, or the walk-in clinics. If you have been seeing a particular physician, how long have you been seeing that physician? How often are you able to see that particular physician, which we all know that we have a lot of people who are attached in this area, but we also have a lot of people who are not able to see their own physicians. So we will ask that. That's based on the tool as well. And the other tool that is dealing more along the lines of OT, we ask them about their mobility and their ability to move and get around even their own home, and how they're getting back and forth to their other clinic and or mental health appointments.
Wonderful. Thank you very much, Dwayne. If you happen to have tools available that you're ready to share, please feel free to forward those along to myself, and we can house and manage those here centrally.
I will do that.
Thank you very much. That's wonderful. Thank you very much, Dwayne.
You're very welcome.
We're now going to welcome Asif Paku and Nina Mugo, and they are both from East Toronto HealthLink. Good morning, Asif and Nina.
Great.
Good morning.
Good morning. So thank you very much, and welcome everyone. I'm going to start and then hand over the presentation to Nina to go into more specifics around the questions that we ask for the interview purposes. So next slide, please. The first slide that we have is around just a general pathway that we use for referral into Ethel, and that would be, we have some programs that we provide within Ethel, and of course then we can also use the partner programs to connect patients. So we do point of care identification. We have at our table all of the sectors: long-term care, hospitals, acute, rehab, CCAC, paramedics, community support services, CODA from community mental health, supportive housing. So really all of the sectors, both health and social services sectors, are at the table. When the client or the patient is identified, they're registered into a database that the point of identification individual would do. They then send that information to Ethel without the entire patient health information. Then there's if there's a need for multiple providers to come around the client or the patient, there's a referral made to the link where either our telemedicine program, our cross-continuum team, which is the rounds that I think Dwayne talked about very similarly, virtual ward, which are at the hospital, and our family health team, also their home visits, and then of course the CCAC programs. And then ultimately, really, the focus is the patient's interviewed, intervention is organized. In this case, if it's a case conference or what have you, and a care plan is developed, then we also do follow-up and monitoring for about 3 months. So our caseload really for the transitional case manager is to hold that client and provide services up to 3 months. Next slide, please. So this is just a quick schematic to show that really what we're trying to do is to help the client, the patient, negotiate the labyrinth of healthcare. And so if we can make it easier for them, that's what we're here to do. Next slide. So we don't have a specific lessons learned slide because what you see in front of you now is really what our lessons learned have been over the last 6, 7, 8 months that we've been using this model. What we found is that we need to first and foremost assume accountability. That's key. We need to identify key partners and, more importantly, create some generative relationships both with the patient, the client, as well as the providers at the table. If we're bringing patients forward to meet a group of complete strangers that they may or may not have seen before as providers, it's key that our caseworkers, our coordinated care, so our care coordinators have developed relationships with the clients. So that's key. There also has to be an infrastructure in place to close the loop, to make the phone calls, to make sure that they appear to the appointment, that we've tracked the referrals, that the referrals are in fact accountable to providing the service that they're agreeing to provide. So those are all the things that need to be done within accountability. There also has to be patient support. So we have to provide them means to get to the interviews, for example, or whether it's taxi chits or whatever they may be. Help them, in fact, even access appointments. Sometimes being a patient advocate or a client advocate is key for them. And another one is really to make sure that we transfer the information over to the organization that we're doing a warm transfer to. So we're moving from one sector to the next, that there has to be information transferred over to them. And we're doing right now, just Nina will mention this a little bit, that we're doing electronic coordinated care plans, so that facilitates the transfer of information a bit better for us. And then the very last piece here that we've learned is around connectivity, to make sure that the information that is collected is standardized to a point that when we send the information over to the next partner, that they're understanding what fields have been filled out and what it all means. And I think I talked about e-referrals, which is something that we're also trying to develop. Next slide. So preparing for the patient interview, very important. I think Dwayne talked about this, and I think the staff at HQO spoke a bit. I'm sorry, the next slide. Yeah, is to really understand the individual patient. So what matters most to them? Why is this important to them? What are their goals? And also what we fail to sometimes remember is that the caregiver, the family caregiver, needs to be intimately involved because they're the ones who are seeing the client, the patient on a day-to-day basis. Next slide. So the process of completion of the patient interview, as I mentioned, we do a referral that is received by the link, and it could come from the hospital, could come from the inpatient or the emergency department, the virtual wards, both in the FIT or the hospital, the community support agencies, could even come from CCACs. What we have as a milestone for us is that we have to contact the patient after the consents have been given within 48 hours. And then an intervention is planned or booked within 7 days. And more importantly, that there was a feedback loop back to the patient, their family, any of the referral sources. They also need to be made aware that this intervention, whatever the intervention may be, has been planned, and this is the date for that intervention. And then we implement that intervention, whatever that might be. So I'm going to stop here and pass the presentation over to Nina, who will actually express the individual questions and the tools that we use for the interviews. So, Nina.
Thanks, Joseph. I'm just going to be talking about that initial interview and just how we start the relationship with the client. So from the get-go, the priority is to ensure that the patient feels comfortable and safe to speak with a care coordinator, being able to express their concerns and knowing that they're being well heard. The meeting is usually arranged to suit the patient's comfort, so it could either be in the community or in the patient's home. So if the patient actually has a substitute decision maker, this person is usually invited to this meeting because it's important for them to be there. So the meeting, the goal for the first meeting is to first and foremost initialize a trust relationship. The case manager or the transitional case manager from the get-go starts off by introducing self and just detailing out to the patient his or her role and the kind of supports that are available from the supports that the transitional case manager will be providing, and also the supports that are available from the care coordination team. Using motivational interviewing skills, the case manager will then ask the client to express their concerns and desired goals. The patient is given ample time to speak about what has been working well thus far and what is not working well, and also point out what, what their immediate needs are. The case manager, being very mindful of the patient goals, will then help the client prioritize the needs to be addressed. So the tools that we use for the interview process for collecting information are OCAN, the Coordinated Care Plan, and the HAMS-8. During the initial interview, after the patient consents to receiving services and signs all the consent form, the case manager will then use a Coordinated Care Plan paper template to gather information from the client. At the point of signing the consent forms, the case manager will ask the patient if he or she is open to having their health record shared electronically on the IAR database. The case manager will usually explain to the client what the IAR database is and who has access to this database. The patient can agree or disagree to have their health record shared on the IAR database. There are tick boxes on the consent forms that usually show what choice the client goes with. The information that ESOL focuses on capturing on the coordinated care plan are demographics, current people or organizations that are part of the patient's care team, what role they play, and how often the patient gets to meet them. So we're talking about doctors, if there's CCSC involved, if there's another organization involved with the client. So we also capture health issues, stable or unstable. We also capture current list of medication, and we also capture goals, addressing what is important to the patient currently or the SPM. We also capture advanced care planning, frailty, ADLs, and other very pertinent information. But the ones that I've mentioned are the ones that we definitely need so that we can be able to plug them on into the electronic care plan. After collecting all the pertinent information, the case manager will then hand the patient the OCAN self-assessment form to look over, reflect, and complete during the week before the next face-to-face appointment with the case manager. This tool is helpful in that it helps both the patient and the case manager flag out other areas of need that were not entirely captured in the initial interview. So the initial interview, as I said before, it can be long. And so we try to make it as short as possible, making sure that the client stays comfortable. The other tool that we use is the HAMS-8 form. We use this tool with clients who have not been identified as high EDE users, but there's a potential risk of ED use and hospitalization. Next slide, please. So as I mentioned, the patient, we make sure that the patient's SDM is present for the meeting, making sure that their desires are also addressed as well. During the interview, the case manager is also making sure that they assess the home. If the interview is actually taking place in the client's home, we're assessing the home. Is it safe? What supports can be put in place for this client in the home? Next slide, please. So after the client is agreeable to coming to the table for a case conference, all the pertinent people are invited to the case conference. These are usually the already existing supports and other supports that we think would be a good help for the client. And this is usually addressed to the client during a face-to-face meeting. So we'll usually tell a client, yes, you need housing, so we're going to be inviting this housing provider to the table. Do you consent to them coming? So they actually have to give consent to the people who are actually being invited to the table. So before the client even actually comes to the case conference, the client is already aware who is coming to the case conference. So during the case conference, we try to make the interview as easy as possible, to make it very comfortable for the client, because we know it's pretty anxiety-provoking being in a meeting in a place full of a lot of people just looking at you and wanting to know all issues about a person. So we give the client ample time to express themselves. And then after the client has expressed themselves, we go around the table and all the care providers can ask the client all pertinent information that will help them figure out how to move forward. So after that, next steps are identified. We usually ask the client to leave the room for about 15 minutes break, and so the people at the table can brainstorm and come up with good ideas to follow through with. Then the client is brought back into the interview room, and then the client is informed who's going to be taking the lead to address whatever goals the client has. Say if the client has 4 or 5 goals, we have different people taking leads on those specified goals that the client has. If it's only one goal, say if it's only housing, then we take one person who takes the lead for housing, and that's the person who will follow up. So what happens after that, we make sure that the client goes home safely. The person who takes the lead has to report back to the care coordinator, who's the case manager, so that everything is, we stay on top of everything. So that's all. Thanks. Are there any questions?
Thank you very much, Stefanina. We do have one question on the line. 2 questions, thank you.
Actually, there's a 3rd question coming in. I'll start with the one at the bottom. Why is the client asked to leave the room?
Well, maybe I can start. What the idea is that sometimes the care team members want to have a conversation where they may have seen something that the client may or may not have expressed. So for the first 10-15 minutes, what we found is sometimes we had a client once who had a bipolar disorder, came with their son, and she really, the questions that were being asked in the meeting, she was very much obliged to, like, she felt she was obliged to give all positive answers. And so and this is fine, so when the patient left, the care team spoke a little bit about, well, can we change the questions a little bit to ask, around some things that she's obviously not, it's not going to be yes and no answer. They don't always have to be a positive responses to this. Let's try another tactic. So it allows the care team to just change the track a little bit. Most of the time, it just allows them to develop a very quick sort of next steps, and they say, no, here's what you're going to do, here's what we're going to do. So the client doesn't have to listen to that bantering back and forth. But when the client comes back into the room, we explain exactly what had happened while the patient was out, and what the decisions were. And of course, they can ask questions or disagree or whatever.
Thank you.
Okay, and just to follow up, there have been some questions about how comfortable, what has been the response from clients about having to leave the room, from your experience?
Some of them are very, actually very thankful to just have that time to be able to leave the room and even just have a break, maybe go to the washroom, maybe go outside and have a smoke. So far we've had positive responses. No one has really ever complained about leaving the room and then coming back, because we're pretty open. When they come back into the room, we do let them know what was discussed, and if there are any concerns raised during the discussion, we also make them aware of that.
Thank you. There is another question. Are you finding the CCP duplicative with the OCAN?
Yeah, this is a very, very interesting question. We had that discussion just yesterday, frankly. It is something that we, as a East Toronto Link, will discuss with the LIN, the Toronto Central LIN, to see whether there is an opportunity to use the CCP as the only tool to gather information. There are a lot of duplications between the OCAN and the CCP, and the case managers would actually tell you that they would prefer to do the CCP because it really engages the client in a conversation and really addresses their goals. OCAN goes into some very specific questions and details, which sometimes the clients may or may not be comfortable. So there is some duplication, and we're definitely trying to reduce that duplication and, in fact, get rid of it altogether if we can. But we need to discuss it with the LIN and perhaps the ministry.
Thank you. One additional question for you. Is Ethel part of the CCT plan of care, and do you have a business process for that? Sorry,
can you say the last piece again?
Is Ethel part of the CCT plan of care, and do you have a formal business process for that, is the question?
Yes, we do, and yes, we do. We, even within the consent forms that we provide to the clients and the patients, it is we are part and parcel of that. So we do, in fact, get consent for us to be involved in our cross-continuum team. And also, it's very similar to the electronic CCP that we're doing. The consent there is also involves the Ethel teams to be involved in the work with the patient.
Wonderful. Thank you very much again, Stefanina. We're now going to transition over to Jennifer McLeod, and she is with us from the Timmins Family Health Team. Good morning, Jennifer.
Good afternoon.
Good afternoon. Thank you. Good afternoon.
So the Timmins Health Link, I guess one of the things that is important to know about the Timmins Health Link is that we really focused on a primary care model. So really what that means is patient care coordinated through the primary care provider and their team. In order to do this, we utilized the patient discovery interview format that was actually a format that was created by some of our HealthLink primary care RNs. So with regard to the Timmins HealthLink, the patient population that we were specifically looking at as we tested this model had been identified through hospital reports that were created for us by our local hospital. We were looking at, as many HealthLinks are, 15 or more emergency department visits in 12 months. So the patients that qualified as a HealthLink patient for us under that criteria. And the other criteria was 4 or more hospital admissions or readmissions in the last 12 months. So as I was saying, the tool that we have chosen to use is the patient discovery interview. It's completed by primary care RNs in our community and primarily in the home setting. The results of the interview are then discussed with the patient's primary care provider and other health service providers that are within that patient's circle of care. As a result of that discussion, the coordinated care plan is developed and created and incorporates an integrated approach to care that meets the needs of the patient as identified by the patient. And as a result of that, the process, of course, involves follow-up by the patient's primary care team and who continue to address the issues as they've been identified in the coordinated care plan. Next slide, please. So one of the things that I wanted to present today is to focus a little bit more on the actual patient interview, and of course, as described by the other presenters this afternoon as well, the interview is actually a component of a process, and this was our process. So our process began with a chart audit. Once the hospital in Timmins was able to identify who the patients that our high users were based on our criteria. And then there was something called a spine that was created. And really what a spine is just, there was a spine created, I'll show you an example in a moment, but a spine was created based on the health issues that were identified in the chart review or the disease entities. Sometimes it would be, a health issue or a disease entity. And this drives the type of interviewing that happens within the patient interview. The interview then gathers information, about the patient's experience in receiving health care related to that disease entity or health issue. Then we proceed to completing the actual interview. As I've mentioned, it's completed on a home visit based on the spine or the template that is created using motivational interviewing techniques. And really our focus is not to gather information about the patient's health status, because we have all that information in a primary care EMR, but really on what the patient's experience has been in accessing health care and our success in actually assisting the patient with the health issues that they've highlighted. You'll see that then we move on based on the interview and the information that's been gathered by the primary care. And the interview, by the way, takes about 2 hours, fairly time intensive. We then can develop outcomes, successes, barriers, gaps, and something called emotional touch points. This is something that is very much a part of our patient discovery interview. The emotional touch points really look at how the patient feels about what's going on. What are the emotions that have been generated? As a result, we also move to setting some goals with the patient, look at their level of readiness, develop goals, and who is responsible to help meet those goals. all of that information gets wrapped into a patient care plan that is the basis of case conferences with care providers, with not only the primary care provider and provider team, but others within that circle of care. Next slide, please.
Jennifer, I do just want to apologize. We're having some fairly significant networking issues here at our Toronto office, and on the slide we're unable to see your visuals. If you could please just speak to the slide, we'll ensure that when we post to our website that all of the technical glitches have been worked out. So we'll listen, and then I will share that out afterwards. Thank you.
Okay. Okay, so yeah, so I would lead you back to the template once you're able to access it. So an example of a spine, for example, I guess an example of a spine might be the one you'll see when you have access to it is COPD. So another example of a spine might be a new page that you may begin to develop on diabetes or hypertension or housing. Ah, you have it there, part of it anyways. Okay, so it could also be related to housing or other social determinants of health. So one of the things that the nurse interviewer will do is they will want to gather information about the patient's experience related to that particular disease entity or health issue. And so they may be looking at, you know, what the patient perceives as wrong, when they've seen their primary care provider related to that health issue or event, what tests they're having, and how they feel about the tests and the results that they've received, what the information they've received about what's happening as a result of the tests, the treatment they're receiving, what it's like to be living with the condition, and then the follow-up. How do they feel about the follow-up that they're receiving, and as a result, are there issues related to that from the person's perspective? So in addition to that, the spine will identify the successes. So what's gone right for the patient in terms of the health care they've received, and then what are the challenges and barriers in addition to that. And that might be an example of that for COPD might be that they are having difficulty affording medications on a consistent basis. That may be an example of a barrier from the patient's perspective. Another component might be identifying gaps in care. You know, and an example might be of that this particular patient with COPD has no primary care provider. So then the emotional touch points that we may identify related to this person's, within this spine related to this person's disease entity is that the patient may be feeling confused, and that the trigger to that might be that when they were discharged home from hospital, nobody really explained what their medications were, and consequently there's confusion around the care that they received. So on the current slide that's on the screen, once, in addition to the spine information, we then are looking at other information that is surfaced as a result of the patient discovery interview, excuse me, and what is most important to the patient right now. So we do try to prioritize all of the needs of the patient to those that the patient feels is most important right now. As a result of that, we then move to action items and try to develop with the patient what are some goals, and what is the patient's level of readiness, what is the action that together we agree is going to be taken, who is going to be responsible for that, implementing that, and how will the follow-up take place and by when. Next slide, please. So our lessons learned have been many. With regard to this patient discovery interview, we were able to determine through some very close monitoring of emergency department visits that the process was in fact effective in decreasing the number of emergency department visits for the patients that we were tracking. However, I'm going to start with the last point on this slide, and that is that while there was close follow-up with the patient, the emergency department visits dropped. Once that follow-up stopped, then we found that some patients, not all, returned to their previous usage. So we know that for some people, that continued follow-up is really important. Going back to the top of the slide, we know that there are many patient benefits. Certainly, customized care plans that are created, that are co-designed with the patient and led by the patient-directed needs, and that's probably the greatest benefit of all. Patients generally feel that they have been heard, and their experience with the healthcare system and in trying to change their health status is improved. Outcomes are improved and gains are measurable. As I mentioned, we did find with a short-term study that in fact was the case using this PDI. One of the other lessons learned as it relates to primary care, and we know that primary care is going to undergo probably a transformation in the province, but the time that's needed for the home visit and the PDI was difficult for the primary care offices to achieve. And was kind of a step out of the primary care nurse's comfort zone. So as a result of that, not all nurses were really comfortable with home visiting. Many nurses didn't have that vast knowledge of community-based services and those that were in the patient circle of care that we might expect people to have. And consequently, in order to implement this PDI and the work with the patient that we were doing, we knew that we would have to schedule time for the nurses to actually go out and do this work, or we would have to modify the process. And that likely is what will happen in Timmins. So all of those things led to many ideas and needs in terms of training and capacity building for the primary care RNs that are connected to our primary care providers. And so as a result of that, this is where we are currently at with our Timmins Health Link, is we value the patient discovery interview and the experience that we've had with it, the experience of patients, but we also need to find a way to ensure that its implementation is realistic and sustainable within the primary care system. Any questions?
Thank you very much, Jennifer. There is one question on the line for you.
Hi there. The question is does your interview include an evaluation of the social determinants of health?
Absolutely, it does. And yes, so I did mention that that one of the spines could well be elements of the social determinants of health that have been identified by the patient.
That's wonderful. Thank you very much, Jennifer. There is an additional question on the line. We will seek to get that responded to after. We are going to now switch and see if we can connect with Tracy and Chris. Tracy and Chris, are you on the line? We're continuing to have difficulties with connecting with Tracy and Chris, and I do apologize. I do know that they had some wonderful information they were going to share with you. They have an interesting process where they support patients by utilizing an interactive care mapping tool. And they also utilize a survey called Be Well that their patients complete. And this supports them in learning more about the patient and the patient's goal. I'll direct you to their website. It's www.nchl.ca, and we'll also seek to connect with them and find a way to bring their information to you in a meaningful way. Thanks again, and I do apologize for that. So what we'll do now is we'll just have a few reminders that we wanted to share with you, and those are the remainder of the webinar series. And so I did want to highlight that there has been a date change and a duration change for the next webinar, which is around care conferencing. The date was previously October 21st. We have moved that back to Tuesday, October 20th at noon, and it will run for 1.5 hours. There's a lot of content and a keen interest in learning more about the care conferencing practices. So we have decided to extend that for you. If you're not able to attend the second half of that webinar, it will be recorded and posted as well. But we do invite you to join us. It should be an interesting conversation. Additionally, the last webinar in the series was originally scheduled to take place on November 11th. However, being Novembrance Day, we have moved that back to Tuesday, November 10th. So please mark those dates in your calendar, and we'll look forward to seeing you then. Next slide, please. And a reminder that we'll see many of you, I'm sure, at Health Quality Transformations next week, and that's October 14th, and that's approaching quickly. Next slide, please. And last but not least, please feel free to reach out to your quality improvement specialist supporting your Lynn region. They have lots of information that they can share and connect with you about regarding innovative practices. Their contact information is typically listed here. If you are not able to see that, please feel free to email into hlhelp@hqontario.ca. That's a great way to connect with us. Also, if you're looking for some of the resources that we've spoken about today, feel free to reach out to us that way too, and we'll share those out. Again, I want to thank everybody, in particular our guest panelists, for attending with us today. It's a great time to share and learn from each other, and we appreciate your participation and your patience with our technical difficulties today. Thanks a lot, and have a great day.